All right, are we good to go, Shelley?
We are.
All right, thank you all for being here. We'll go ahead and call our meeting to order. It's spot on 9 o'clock. Welcome to TEPI. Shelley, we do have to do official roll call.
We do. All right. Allison Welch.
Present.
Barbara Sullivan. Thank you. Candace Williams. Harry Good. Christopher Felton.
Here.
Corey Usher. Dale Woolridge.
Present.
Jennifer Kick.
Present.
Darth Gamer.
Present.
Heather Miller.
Present.
Josh Gaither. Julie Augenstein.
Present.
Laura Smith.
Present.
Maria Salas.
Present.
Michelle Guadnola, that should be absent. Paul Dabrowski. Zane Kelly. Dr. Kelly.
Here.
Raymond Proa. Shanna Clough.
I'm here.
Thank you. Sean Boker. Phoebe Merrill.
Present.
Tiffany Streever.
Present.
And Tom Flanagan.
Present.
Great. Thank you. We have forum.
Excellent. Thank you all for participating today. A few brief items to touch on. First, of course, is the attendance report. Just a friendly reminder to take a look at that. If you are unable to attend 2 meetings in a row, the Bureau staff will reach out to you to determine if you still want to participate in this committee. But thank you all for being here today. We do have vacancies. We have a vacancy for, and we're going to talk about this later on in the agenda, the role of a law enforcement representative with active involvement in EMS, and ADHS Injury Prevention Advisory Council representative. You can see there, please submit a CV/resume to Shelley if you are interested in filling these positions. Also on the list is the 2025 meeting schedule. Please take a minute to look at that. There are some small changes from last year, so make sure that matches up with your calendar for this year. With that, I'll hand it over to the Bureau staff for the rest of the report.
Here we go.
Yeah, I can talk about this slide. So just want to congratulate Leah Castro. So she has been promoted to our certification manager, which is the position that was vacated by retirement in November. So we're really happy to have her starting in that role. As well, Brent Caswell, who has been acting in the capacity of enforcement program manager, is now our permanent enforcement manager in our compliance section. And so a big congrats, and we're happy to have Brent. His time in acting didn't damage him, and he's willing to stay on as permanent. So we're happy to have him join. And then also we welcomed Stephanie Cartwright, who's our one of our new CON administrators. As well as Mitch Adair and Lance Bevins, who are both now permanent with the Bureau in the roles, also in our enforcement section. So we've had quite a number of vacancies. We also do have a Bureau Chief position that we are still actively recruiting. It's been a long recruitment, and it will continue to be a long recruitment. I think I've stated before that we're definitely committed to making sure that we fill that role with the right person and the right fit. And so that's ongoing. So if you please share it, it is on our job site. And if there's any issues, I know we have had some issues where it come down, please definitely flag those for us so we can make sure that we get it corrected, and appreciate your support in promoting that role to all of your anyone you know who might be interested. We also have the role of, and Kim could probably speak to it more, but we also have the role of trauma compliance officer that is also currently posted. So hopefully very soon we'll be back to full capacity with the Bureau, but those are just a few updates. I'm happy to answer any questions that you might have on any of the roles that we filled or have vacant.
Nice, make the slide change.
Okay, so we have our upcoming EMPT and of the Year Award. So those are still currently open. Just a reminder, these are through the regional council. Anyone can submit anyone to be nominated. The regional council will then select the awardee, and those awards will be given out at the May EMS Council meeting. So just wanted to make sure that everyone knows that this is open. Please take the time to nominate the individual. Next is the Trauma Award. This is our second year of doing the Trauma Award. There are going to be a total of 8 individuals to be recognized for their different roles within the trauma system across the state. We have a committee of individuals that will be reviewing those. They're all outside of the Bureau staff that will be reviewing the nominees and determining who will be the awardee. So please make sure you nominate some individuals for this. Last year, we did have the pediatric one that remained open. No one nominated anyone for, so please make sure you take some time and hopefully we can get all of those awards given out this year. Yeah. Thank you.
Sorry.
Sorry. Happy clicking. The EMS and Trauma Award timeline is up here, so you can see that we opened this in January. We are in that cycle currently, and then the awards will be given out on May 8th. EMS portal changes. I can cover this briefly. This is just a reminder for everyone that the portal has been updated. I think the biggest thing just for everyone to know when they get their certification email, this is now coming from a .com. This is kind of just the big thing because .gov generally does not get filtered out by spam. Some spam filters will filter out a .com email address. So just making sure your personnel know to look for that. They will get the 90, 60, 30-day reminder for their certification. So there is quite a bit of time frame. But just wanted to keep highlighting this as this is a new change from the email component. Other Bureau updates and news, you can see the link here to the Bureau statutes and rulebook. This was updated beginning of January. We also have some links on the slide deck for heat data as well as opioid news. I know we have had a pretty nice March so far, but it looks like we're going to be in the high 90s next week in Maricopa County. So hopefully it's not forecasting the summer, but definitely are trying to track the heat data early. So I wanted to make sure everyone was aware that those 2 dashboards are available. The slide deck will go out after the meeting, so you'll have the hyperlinks to those if you are interested. And we also shared some communication about National Poison Prevention Week. So if you are signed up for our delivery, you should have found that email this week. Just highlighting several links, which are quite useful for this poison-related outreach endeavors. Scope of practice, we're going to keep highlighting these slides probably over the next year. We get quite a few questions. I would say probably weekly, I get questions regarding scope of practice and drug table. So we want to make sure that everyone is aware this is a huge undertaking that the committees worked on last year. So throughout 2024, and this went live on January 1st. So this is the updated scope of practice. Include the addition of the EMR level as well as the critical care endorsement level. So just wanted to make sure that everyone is aware of that. If you need a quick link to this, if you go to the Bureau's main webpage, the bullhorn at the top has a link to the scope of practice. This includes all the different FTRs and everything that is required for critical care endorsement. Right. Drug table, there was also substantial changes for this. I want to highlight this. The big question we're getting is specific to hospital-based paramedics. With the addition of the critical care endorsement, there was a shift that the committees made in regards to what treatments can be done by paramedics in a hospital setting, which is your table 3B versus a paramedic with critical care endorsement. So please make sure if your facility is using paramedics in the clinical setting that you review that list to ensure compliance with the updated drug table. So we will keep highlighting these. This is also available both in the slide deck that will come out, but on the Bureau's webpage, it's the hyperlink to the bullhorn section at the top as well. And the Watson, Dave, I don't know, are you online to cover it? Otherwise, I can cover this here.
Handling this group.
Okay. I can cover this then. I think the big thing we wanted to say is really looking at the numbers from the naloxone leave behind and how impressive these numbers are. We are now up to 53 EMS agencies in the state, which is really remarkable. I think when we initially started this program, we were thinking maybe if we could get to 15 or 20, that would be a success. And the fact that we're up to 53 EMS agencies, almost 4,000 EMS personnel trained. So we're getting close to the 25% of all of our certified EMCTs in the state of Arizona who are trained in naloxone leave behind. And as we see the number of agencies increasing, we are seeing the number of kits or scanned out that go out into the community. We're up to 857. So these are going up. We get kind of a weekly tally pretty rapidly. So really excited to see this. We know that quite a few more kits are given out in the community. One piece we're trying to remind everyone is the QR code that is on the kit is the same regardless of which kit it's on. So it's the same. So if the personnel hand out a kit, they forget to scan it then. They can still scan another QR code at any other time and put in the actual zip code and agency that gave the kit out. But just a reminder, I don't think everyone was aware that the QR code is not specific to the specific kits.
I'll just highlight, I think, on the naloxone piece as well, that it is one of the key indicators. So we're really happy to see this launch, happy to see it continue to grow as well. In the prevention division within public health, they also work on naloxone distribution to a broader set of community agencies. And is one of the key indicators that as an agency we are reporting under our strategic plan, which reports under the governor's priorities, in particular when we look at our life years lost, knowing that unintentional poisoning or unintentional injury is one of the key indicators for life years lost. So just also highlighting the connection that some of this information is highlighted in key and what we report as an agency and one of our key goals that we report to the governor's office as well. So thank you all for your participation in that and really looking, and for the, for Dave and Adam and his group for continuing to work with you to get it expanded. We're excited to continue to share the progress on that.
Thank you. Next, we have the Arizona EMS for Children Pet Flow Guides. I don't know, Adam, if you wanted to cover this briefly, or Adriana's on the line.
No, Adriana's on the line, but I can say a few words. So these tech roll guides are a portion of our program that tries to ensure that there's pediatric champion or at each agency, and there's no require at each agency. At any agency, we can find someone to represent its division at. It's not its own hiring funded position. It's more of a voluntary position that we hope somebody with passion for pediatrics will make a connection with us, and then we can use them as a conduit for information and resources. There's two role guides because we have techs in two main locations. One is in the hospital setting, and one is in the EMS in the pre-hospital setting, and they have slightly different information that goes along with them. But you can definitely scan that QR code to find out more. Oh, and I can give this up to you. So we may cover this later on the agenda, but we are looking at validating a newly developed method for automated case matching. The previous procedure was somewhat labor intensive. And so with the transition, the shared data team has been trying to structure a more automated way of capturing that data. In addition to that, an update to look at where we can lie with national standards is what maybe standards might not have been the right word, national practice, I think. And so we are attempting to make a few changes at once, which is to shift to a different data collection method. We were attempting to shift to a more automated process, and therefore make the ultimate goal, instead of a share annual report, a share dashboard that can be called upon. And I think we can talk a little bit more about this. We get the agenda. That's what I have for that side. Thank you.
All right, I will cover this slide. This is just a reminder. We are going to go into this a little bit more detail later as well. This was the update for the Premier EMS Agency Program. So this was approved by EMS Council last May. This was the addition of the specific data elements for cardiac arrests of the shared data elements for the PEEP criteria. That data collection started in January, and I will go over kind of how we're looking in terms of those reports a little later on the agenda. Next slide. Yeah. And wanted to update our dashboards. We will always include the links to these. Sometimes it's a little hard to find things on our bureau's website. So it is nice to know that these are kind of easy to find from the slide deck. We do have updates to both our EMS and trauma data dashboard. These are incredibly useful. We do know that several agencies throughout the state have used some of this data to actually apply for grants, both at the federal level and really get some significant funding. So please feel free to go to those links, look at that data. There's a wealth of information, both regarding EMS data as well as trauma data. For trauma centers, if you're looking for any trauma outreach, injury prevention information, there's quite a bit on there. We have information specific to off-road vehicles. That was one of the big accomplishments that the Bureau really had in 2024. And this legislative updates that were passed to help improve safety really to off-road vehicle use. So really looking to highlight that information. Carissa, are you on the line for trauma registry update?
Yes, I am. Good morning, everyone. So we migrated over on January 1 from Trauma 1 to the new ESO patient registry, for those of you that are web-based. So just a reminder that all of your 2024 records, so fourth quarter, they're going to be closed out in Trauma 1. And then January 1st onward, we'll go into the new registry for web-based facilities. So this coming April 1st is going to be your last quarter that you're going to be submitting through Trauma 1. And then the first quarter of data that will be submitted is going to be on July 1st, and that'll be first quarter. And that's for web-based as well as hospital users. So even if you're still on the non-web trauma one, you're going to be submitting data to the new registry, and we'll be doing trainings before that. And then also the next big kind of step on the timeline here is we're going to be migrating over the legacy data from Trauma 1 to the new registry beginning in July. And then if anyone has any questions, they can reach out to trauma training at ESO, and that's for any kind of weird validation flag, things like that. And I also just wanted to say thank you. I've worked with a lot of you. It's not easy to transition from a system you've been using for 20 years to a new system. I know there's been bugs and things, so I really appreciate everyone's patience and participation in our weekly meetings and things like that. So we're still working out a few bugs, but I think we're making good progress. So I appreciate your guys' patience with this. And if you have any questions, you can always reach out to me as well.
I just want to give a shout out to Carissa. She has been fabulous, always available for questions, concerns, and this has not been a smooth transition, and she has been fabulous. And so I think she deserves a lot of credit with this.
Thank you.
Feedback, Tiffany. This is a link to cover the some opportunities for some Safe Streets for All grant funding. This is a huge appropriation that is over a 5-year period. Was really large dollar amount. That's be up to $2 billion being made available at the federal level. This is open for jurisdiction. So as an example, the Bureau of EMS should not apply for any of these, but we do want to highlight these are open for any bureau or different jurisdictions that are interested in looking to this. There is some funding opportunity. I don't want to put Dr. Gates on the spot, but maybe you can speak just on the funding.
Yeah, we did a nice webinar yesterday on this. If you want to be tortured by my ugly face, talking to you, you can hear about our program on the NHTSA and DOT websites for this grant. The short version of this is this funding is very easy to apply for. The application is short. They range from 2 to 10 pages long. There's 4 different types of funding you can seek. Planning funding, which is generally a public health activity for the county public health departments, or demonstration and implementation projects, which is where we fall into this. In Southern Arizona, we got funded to do a demonstration project, really implementing our Physician One program, where we will have a physician available to respond to highway traffic accidents 7 days a week as part of this grant funded program. So take a look at that webinar. There was some great information from the DOT and FS4A leadership teams. It's worth your time.
That's the end of our slide deck.
All right. Strategic plans.
Is it still funded, as far as you know? Just all the cuts. I just don't know if there's like actually money for that anymore.
Yeah, I mean, I can only share my personal experience. I'm not a member of the staff here or the member of the DOT. They called me an awarded member. So they consider that they funded our project. That said, I do not have a contract to do the work. So, yeah. Sorry, Shelley, the item D, strategic plan, did you want to touch on that or are we saving that till
I'm
later?
gonna turn it to Nicole. Oh, to talk about the strategic plan?
Yeah.
Oh, thanks.
Thanks, Shelley.
So this had been on agenda and I think we had, we kept pushing it forward. So we have a process for approval for our strategic plan as well. And Julie is absent, so I know is doing a lot of leadership around this. She'll be back hopefully next month and can continue the work towards our strategic plan. But wanted to talk about it today because I just wanted to put out awareness that we are looking to start work, and maybe Gail can add on developing the work group. So you know, a lot of work has gone into that strategic plan to provide stakeholder engagement. Our intention is to report on the strategic plan annually, which is required by statute. So our progress towards the strategic priorities that you have all identified and informed us through that plan. And so I know it's been a little bit of a slow start since it was approved in September, but then from this approval, it went to the director's office and then the governor's office. And so now we just are happy to move towards starting to establish those work groups so we can really dig in and actually start to implement and action that strategic plan. So Gail, if there's anything you want to add.
Yeah, thank you for everyone who did participate last year in that process. We had several stakeholder listening sessions across the state with all the regional councils, along with multiple different organizations. And then we had the strategic planning summit that we held here with over 75 in-person attendees for that. I think we have a really good plan of what we would like to do from a work group perspective. So hopefully within the next month, we can start looking at forming some of those groups, bringing stakeholders in from across the state once again to start addressing some of those pillars in our strategic plan. The strategic plan is for 5 years moving forward, but starting in 2025 through 2030. So while we're a little bit off the schedule, I think we were kind of in a well-positioned place at the end of 2024 when that was approved. So still in that very early timeframe before we need to initiate the strategic plans.
All right, thank you guys. Next up, let's move to agenda item 5, unless there's anything else from the Bureau. All right, can we start with Maria, trauma registry user groups?
Good morning. Well, just like Carissa mentioned, we started the new registry program on January 1st, and we're coming along. A lot of the validation errors have been fixed, and I mean, there's not much. We're just still learning. A lot of videos out there for building reports and stuff. And like Tiffany said, a big thank you to Carissa. She's been a big support. We keep bugging her every day with emails, and she's always answering right away. So thank you, Carissa. And that's it on my side for the truck group.
Thank you, Maria. Next up, Heather, trauma program manager workshop.
Yeah, so our last trauma program manager workshop was on January 31st at Banner Desert. It was a good meeting. They touched base on non-accidental trauma, had some discussion like everybody's talking about on the trauma registry update, as well as some PI cases, alcohol misuse screening, and a Stop the Bleed instructor course. Our next meeting is June 27th in Flagstaff, and we're looking forward to that.
Thank you very much. Next up, Ray, I saw you join. Update from EMS RUG.
Yes, good morning, everybody. We had our EMS RUG meeting on January 9th. So some of the stuff might be a little behind since I joined a little late, and if you heard already. Covered the interim directors with Nicole Witt and Noreen Adler. We talked, Adam Rodriguez was covering some more other stuff. If anybody need anything for section chief, I believe the MARC program had launched and they were taking applications till February 14th. Covered some of the data that was already talked about with premier's agencies as far as it was live and it was now required as one of the shared data elements for cardiac arrest, things like that. The updated scope of practices were live. Hospital coordinators, I believe Ann was, correct me if I'm wrong, Ann was working on a Google sheet for the hospital coordinators for new users and the hubs and people be able to join really easy onto their agencies. We did some AZ peers, some of the new data visualization that's in the actual AZDHS website, such as the presets for 911, EMS incidents, things like that. There's a lot of great stuff that's been put there. If everyone has a chance to go and look at it, it's like I said, it's underneath the data visualization there, and it uses all the data that throughout the state. And I believe everything from 2023 has been added, and hopefully 2024 by this time, since we're about 2 months ahead of our meeting now. And then the big thing was, Ann would, if everyone gets a chance, you should be getting your run reports, should be getting your run reports every week. And if you can, please review them and make sure that those numbers from the state also correlate with your numbers that you're using in your agency's EPCR. And then let her know if for some reason some of your reports have not imported or have not, they're not in there. So you can either re-import them or do what you can to make sure all the data matches up. Went over some of the new public data portal dashboards. The new data for urbanicity reports. I believe it was actually supposed to be ready by March 2025, so it should be ready now. She wanted to thank everybody in the agencies for syncing their rosters and keeping them updated, since they now sync with the new AZ peers rosters as well. So you don't have to do it once. Then they're also covered the new AZ Peers Image Trend Report Writer. There's a bunch of new reports in there. They can be altered and changed as needed. One of them was EMS Compass, which uses the new NEMSQA. For those that don't know what NEMSQA is, it's the National EMS Quality Alliance Group. It uses a lot of things for cardiac arrest, has a bunch of data points, and they've been all added in that folder. So feel free to everyone go into your report writer, look at your EMS Compass folder, and check out those reports. There's a lot of national people have heard, Jeff Jarvis, things like that, and NEMSQA that are doing a lot of good work there. We talked about the NEMSIS 3.51 update, which I'm not sure was ready for the new update, but I believe it's, according to my notes, it's supposed to, they'll be able to take, unless something's changed for the deadline, NEMSIS would be able to start using 3.51 in June 2025. That may get pushed back, but from what my notes are saying is AZDHS probably is not going to be able to take 3.5.1 until after 2025. So no panic or anything like that. And then that was about it. So it was a great meeting. There's a lot of stuff. It went through really quick, and got it all knocked out in an hour, and it was great. So thank you, everybody.
Thank you very much. Next up, let's move to our discussion and action items. First item on the agenda, discuss and review / approve the meeting minutes from November 21st, 2024. Can I have a motion to discuss and approve?
So moved.
Thank you, Garth. Second?
Second, this is Sean.
Thank you both. All right. Any discussion, questions, or concerns about the meeting minutes? I will give you another 30 seconds to move through, and then I'll ask for a vote. All right, hearing no discussion, let's call for a vote. All those in favor of approving the minutes as presented, please say aye.
Aye.
Aye. Aye. Aye.
Any opposed, please say nay. Any who wish to abstain, please say aye. All right, hearing no abstentions or no votes, we will approve the meeting minutes from November as presented. Next up, Adam, can you lead the discussion on the share registry update?
Yeah, absolutely. I wanted to sit there to give a little bit more of a comprehensive update for members' understanding of where we're at. And so since 2008, we've been matching cases from pre-hospital and hospital sources in an engine called CEDAR. This was a homegrown application from University of Arizona that we've recently taken over. The hospitals would go in there and put their information in, and then AZ peers, the correct data set from AZ peers would be pulled in, and then all the matching would be done in there. And that was what I was mentioning, that process was a little bit labor intensive. And at times did rely on like narrative parsing to see just to make sure that we have the right cases. And so that inherently is a little bit time consuming. And so we thought it would be beneficial to have an update that would help automate this process. And that is a process that I'm not going to remark too much upon, because it largely lies with my data and quality assurance team, who's using a number of different acronyms for software that I don't know what they do, but essentially machine learning and to make that process a little more streamlined. So during this, it seemed natural to attempt to align with our national standards, national practices, so that we could be included in the conglomerate of information from the rest of the state. And so purchasing a registry was immediately challenging, and it wasn't a viable option. So we thought maybe we would just align very precisely so that they can use our data, so it's so we're included in the national consideration and scheme of things. That challenge is pretty great when you consider the existing data entry form has 100 data points of information to enter into it. And what we're looking at going to has half a dozen questions that are required. And so trying to find the mapping between what we've been asking and what we're looking at moving to asking, which is to say that the shift to national standards, trying to find the mapping so that the data from 2008 until now is congruent. So it continues. You can use it as a tool for information all the way through. And so that is one of the deeper challenge mapping process is what we're calling that. That's been one of the more complex challenges. Some of the questions are slightly different. We're trying to figure out how to handle that. Some of the drop-down menus have slightly different changes, which sometimes they have direct mapping and sometimes they don't have direct mapping. And so to be fully transparent, we fully expected to have a report out by now. And I totally apologize for not having it, but there's been layers of technical difficulties as well as funding has also had an effect on these processes. That's not to say we haven't accomplished major milestones in the production of the reports, like we've identified the correct patient population from the EMS side. We're certain of that. We're still trying to figure out on the feeders. We're still trying to narrow down the population with a high degree of certainty on that side. And so that we are making progress towards it, but I wish I could tell you it'll be ready in a month. Because I would have said that a month ago, and I wish I could tell you it would have been ready 6 months. You know what I'm saying? And so I do assure you that a lot of people are working on it. Half a dozen of our team members are working on it on a daily basis. So I'll pause there for any questions, or Dr. Bradley.
Thank you, Adam. I think there is a huge amount of work when we look at the original shared database. This was really groundbreaking nationally in terms of cardiac arrest data collection. But this really started in a time frame where most of the records were actually paper records at that time. So now that we are in the era of electronic patient care records, we really want to try to automate this. And this was a big push behind really establishing the PEAK criteria. What we'd like to do is all of the data elements are NEMSIS 3.5. So the NEMSIS 3.5 update that went live actually adopted all the cardiac arrest data elements, made it consistent across all vendors. And so that kind of made it easy for us to say, let's make this a data standard across the state. And that is what EMS Council approved. So we are very thankful that that is in place now, because I think over the next year, we're really going to be able to get almost all of our EMS data directly from the EPCR record, as opposed to having to do kind of manual pulling of information. With the advent of technology, there is some work that's being done by Vauxhall and Josie, who are really looking at using some of the machine learning to actually pull some keywords out of narratives to try to make sure we have the right patient populations. So actually moving forward, I think we are going to have more accurate representation of cardiac arrest in the combination of what's being used in the cardiac arrest data elements, the drop-down field, in addition to some of that machine learning from the narratives to kind of pair together and get the right and correct patient population. In regards to the hospital data set, we really are trying to align with CARES. So CARES, I'm sure many of you have heard of that. That is a national cardiac arrest registry. In the United States, there is a little over 40 states that are currently participants in that program. Arizona is not currently a participant, partially because we've had the SHARE program historically. But what we are looking to do is align our data elements. So we recognize that it is a huge lift. For many of you representing hospitals, you are the ones doing the big lift of getting all this information. It's inputted into CEDAR. And so if we can go from 100 data elements down to 6 or 7, I think that workload dramatically decreases and will be much more easy for people to adopt. We are just trying to figure out the best platform in order to accomplish that. And recognizing that, do we decide at some point to say our database is going to look different moving forward than it had historically? So that may eliminate some of the comparison of data. So just one of the things that this committee may be apt to look at is if we completely change some of these variables to really be more up to date, are we looking at really apples to oranges comparison versus saying what we're seeing now looks very different? We want to make sure as we make any changes, when people go to a dashboard, they don't suddenly say, why is survival decreased, or why do we have so many more cardiac arrest in the state, just as an example. So those are some of the pieces that we have to really work through in the process. So we appreciate everyone's patience with that. I think the next piece to cover, which is kind of looking at the premier EMS agency data for out of hospital cardiac arrest. So we have had agencies starting in January wanted to know what their performance was, and we've had to say, well, the collection period started in January, so we need some time to actually collect that data and review it. And have started to pull some data for me. I have a report that I've kind of started to review. And it looks like many of our premier EMS agency program agencies are doing quite well. So our goal is to really figure out how we can best present this to the agency so that agencies can see how they are doing in regards to validation scores specific for share. And then the next step will be to say, if you're having some gaps, what are some elements that we can do? If it's an issue with how your data is being mapped to your vendor, or is it truly that your personnel are not filling out those data elements? But either way, we're going to work with agencies to help maintain your team status. Our goal is to ultimately really use 2025 to improve this data set and automate it. We're not looking to eliminate anyone from the PEAK program, but we are going to hopefully within the next month start getting reports out there. One of the pieces that we do want to recognize is how do we communicate back to agencies. If you are a PEAK agency, Dave Harden should have your information. We are going to use that list as to who the report goes to. So if you have a change in personnel at your agency, please communicate that to David Harden, and that way we can make sure the report goes to the correct individual. And I'll open it up to questions. I know that's a lot of information from both Adam and myself. We wanted to give kind of a little bit more global overview of where we are with the SHARE program.
Thank you, Adam and Gail. Questions, comments regarding the share registry?
Question. I feel like in the past, the state wasn't accepting like unknown, like there's tick box are known for like time of arrest, for example. In the new, will that be an acceptable response for some of that time of arrest? I believe that's going to be pulled from the EMS data set, and we're no longer be adding that information to the hospital. Are you talking about the EMS data that being checked unknown? Yeah. I don't know. That'll probably be one of the discussions to will we accept that or not. It's a really good question, Matt.
I think Anne is on the line, but I know we did actually, those are some of the things we had gone through with this committee a couple rounds ago. Yeah, so we did address that when we approved those data elements. So there's ways to kind of work around that in terms of the specific question.
Someone else?
I just want to say great job. I think it's really exciting this finally kind of coming together. So I really appreciate the work that the Bureau has done to, investigate things like machine learning and really trying to make this a very accurate and robust database. I think that even looking at a lot of the CARES data, there's probably a lot of missing cases and some other things. So I think the attempts to make this really, really correct and robust is a huge lift, but I think it's going to be really, really great in the end.
Thanks, Joe.
Other comments? I'll just add on to Dr. Rice's comments. This data is incredibly important to medical directors and EMS system leaders. We truly do use this as a benchmark for our overall performance of our agencies and personnel in the field. So thank you for continuing to work on this. We know it's not easy, trust us. No one thought this was going to be easy.
I know that you know.
We certainly appreciate all the work and effort and understand there will be delays. So thank you. Awesome. With that, let's move on to item C, discussion of the ACS verification trends.
Want me to share? I can give a little background before I can start this. So this was actually presented to that, but I wanted to have this presented to this group as well, just because we have so many trauma program managers that do participate in this. Oh, sorry. This was in regard to a change in some of the verification trends we're seeing across that have been across the state. And so I'd asked Kim if she was willing to present this, and she put together a really nice presentation. So I will hand it over to Kim.
Okay, my name is Kim Bain. I am the Section Chief for Pre-Hospital Coordination Trauma Services for the Bureau of EMS and Trauma. And just to start off, I just want to make sure that it's clear that the department does not in any way represent ACS. And this is just for informational purposes only on kind of the trends we're seeing in the state. This information was gathered from my personal notes attending these visits, and then also from the resources for optimal care of the injured patient, which is also lovingly called the Gray Book. And if you have any questions specific to the ACS standards or how to meet them, I encourage you to visit the facs.org website. Just some reminders to think about in your exit interview. Verification standards are divided into type 1 and type 2 standards. The type 1 standards are considered critical standards that directly impact patient care. And so those are the most critical of standards. The rest are kind of fall into the other category. And this is one really important slide, I think. The exit interview reminders continued. If you're compliant with all of the standards, you get a verification for 3 years. If you're non-compliant with up to 3 type 2 standards, you can be verified for a 1 year. If you're non-compliant with any type 1, which again we decided was those negatively affecting patient care, or non-compliant with more than 3 type 2 standards, you may not be verified. And the adherence is not verified, but you see down there in the asterisk, final decisions regarding compliance with the standards will be made by the VRC committee and may differ from the findings stated at the exit interview. So most importantly, this last, back in December, we had a site that would have fallen under that non-compliant with more than 3 type 2 standards, but still got a 1-year certificate. So there is a lot of variance that can happen with the ACS. My personal view on that would be is if you feel as though you fall into the that category of a type 1, definitely reach out to the Bureau. If it's more than type 3, you probably want to let us know so we can start working on a plan D should the college come back as not verified. We can kind of try to work with you and see how we can mitigate your time as not being verified and or keep you verified if that's an option. Over the last 12 months, there's been 12 facilities that have undergone ACS visits. One was a corrective action visit, which was kind of a follow-up 1-day visit on a previously identified instance of non-compliance. We've had 2 facilities that came out of their site visit with 0 deficiencies or 0 instances of non-compliance. The remaining 9 received focus visits or they had non-compliance standards above that of the 3 that would enable them to be verified. ACS has started to do something that the state has already done, and that is there's a difference between having a site visit where we're looking at those instances of non-compliance that require a site visit like patient care record and things like that, to the administrative sort of thing like staffing shortages, a response time, things that you can monitor with metrics and submit paperwork for. So not all of these visits are on-site visits. Some of them are resolved through paperwork and can be resolved at any time during that 1-year period. So if you resolve your staffing issues within the first 4, 5, 6 months of that year period, you can turn that documentation in and get your second 2 years. Doesn't have to wait until that 1-year mark.
Can you go back to that last slide? So I just wanted to point out, this is a substantial trend, and kind of one of the things I had noticed as I was getting these renewals that come through on email to us is if you look at your 9 out of the 12 got a 1-year verification cycle. So that is really unusual for the state of Arizona. So we wanted to make sure that we pointed that out because that is a big change. This is not just specific to Arizona, and talking to the other medical directors across the country, other states have seen the same trend. But we wanted to really bring to this committee, this is very different. So if you think about it, really only 2 out of the 12, I got a full 3-year cycle. So that's a pretty significant change. Tiffany?
And when we were at the TEPI or at the TQIP conference in November, they had a slide, which is the big committee DI committee meeting that we used for benchmarking at the ACS. They had a slide. There were just less than 300 facilities that had gone up for verification or re-verification in the first 12 months of the new charcoal books or ebook, whatever we call it. 56% of those facilities either failed outright or had a 1 year. So, I mean, it is, as you said, Dr. Bradley, it is universal. It is not. So, from a facility, perspective, there's a lot of changes in how the ACS is looking at the data, and I think it's made a change.
Is there a trend in the reasons for non-compliance? Is it mainly staffing or?
Yep.
And
Next slide. Next slide. So I do also think it's worth noting that this last 12-year period that the 2022 standards actually were rolled out. So that gray book, we've moved from the previous book, which was the orange book, to the gray book. And I think anytime you roll out new standards, there is going to be a period of adjustment. In this gray book, they have put in more standards when it comes to staffing. And when we look at the deficiency breakdown, they have 22 total deficiencies across the 9 facilities that had that third category. And as you can see, the majority of them fall under registry or PI staffing. So that's 4, 5, 6, 7, 8 of them right there. 4 facilities have their patient record. They are now requiring a specially certified registrar be involved, and that's that CAISS person. And then just flat out FTE requirements, which is that next one down, and then the performance improvement staffing. The trauma registry patient record completion is not directly tied to, but kind of to staffing. ACS says that you have to have 80% of your charts in 60 days. So obviously that's a reflection of if you don't have enough registrars inputting, then you're not meeting that metric. So you can see that's where most of those are coming in. The next ones we have are mental health screening, which that is a newer screening that they have, and then the alcohol misuse intervention. I have seen that the screening have been more compliant, but the actual interventions that follow up on the screening are what hasn't quite caught up. Moving on, they have instituted, this has always been a standard with ACS to my understanding about your neurosurgeon orthopedic response and IR. However, they've defined it differently. And they've been asking for specific metrics where before I feel like it was more of a, I don't want to say on your honor, but they're looking at it much more closely. And they have put in specific instances to in which you are calling your orthopedic surgeon, you are calling your neurosurgeon, and specific times for needle puncture for IR. So those have just been a little bit more specific, which is where I think are having a couple of facilities up. And then I just kind of threw in some of the other ones that you're seeing. We've just had one that was related to PI and some other just disaster management, reporting structures. All of this stuff is, I'd say the first 4 on that bottom list probably are all paperwork can be resolved, just by adding a dotted line or a straight line on a org chart for some of it. But so that's what we're seeing as far as those deficiencies and breakdowns and possible causes. Any question?
Thanks very much, Kim. Any questions? If not, we'll go ahead and move to the next agenda item. All right, next up, the last item on our agenda is to discuss, amend, and approve the bylaws changes to address some long-standing member vacancies. And I believe in your packet, you have a roster. And you can see here, we do have 2 long-standing vacancies. Shelley, is you?
Not really, but a natural expansion would be to offer each region.
Thank you. So, we like to kind of keep the membership as broad as possible to really have good representation across the state. But as you can see on the roster, we have line 10, which is law enforcement representatives with active involvement with EMS. We did have someone many years ago who was a very active participant in this committee, as well as some of our other committees, but they moved on to other roles within their agency. And so this has been vacant for years now. And then the other one is for the representative from Injury Prevention Advisory Council. Again, another vacancy we've had for quite some time. And so wanted to bring this up to the group to see, do we want to consider, as we have many people throughout the state that want to participate in these state committees, as opening this up. One opportunity, as Shelley was pointing out, is line 6 through 7. It's kind of an odd way that's formed in that we have 2 regions that share one spot. So I don't really know. It's kind of eeny, meeny, miny, mo as to who gets it each time. But this might be an opportunity where we could give each region a representative if we're looking to potentially make those changes. So not that we don't want representation from the 2 groups, but with those being vacant for many years now, I think we do have the opportunity to consider amending the bylaws to open up for those 2 positions. So that is the background.
Thank you. Other comments, questions, suggestions? I'm happy to entertain a motion to expand line 6 and 7 and eliminate line 10 and 13, if that is in the interest of the group.
So moved.
Thank you, Tiffany. Anyone
Second.
want a second?
Second.
Thank you. Thank you, Garth. Thank you, Garth. All right. Any discussion on that? Silence is golden. We love it. You hate it. Speak now. This makes a lot of sense to me personally.
I agree.
Concur.
All right. Hearing very limited discussion, I will take this as broad support and call for a vote. All those in favor of expanding line 6 and 7 and eliminating line 10 and 13, please say aye.
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 Nice. Yeah. Any opposed, please say nay. Any who wish to abstain, please say aye. Excellent. Hearing no abstentions or no nay votes, the motion passes. And Shelley, just to be clear, we will expand line 6 to be 1 for Staines and 1 for Ames. We'll expand line 7 to be 1 for Names and 1 for Wacoms. And then line 10 and line 13 will be eliminated.
I like it. Thank you.
Thank you all. All right. Sorry, I moved my agenda to the back because of that. Next item, call for agenda items for the next meeting. Please let Shelley know if you have items you'd like to discuss at our next meeting. Call to the public. All right. Hearing nothing, let's take a peek at our upcoming events. You can see an entire list there. Spring is always a good time for EMS activities, and we do have several listed there. Feel free to click on those links for those of you participating virtually for more information. You can always visit the Bureau's news and conference page for additional upcoming events, as well as training programs. With that, the next meeting is July 10th, 2025, right here. Same time, maybe same place. Thank you all for your participation. With that, I will adjourn the meeting and see you at the next one.
Thank you.